Thank you very much, Manish. It's a delight to see you here today, and I'd like to thank Dr. Lalit and Dr. Jasuja for having invited me. I will be discussing proton therapy in oral cancers, and I'll take a slightly circuitous route to get there because I'm so happy to have you here as an audience that I want to share just a little bit extra. So, as you see in the world, we see that proton therapy installations have, increased 9 times in the last 20 years. And when we look at the number of proton therapy centers in the rest of the world, there are 42 centers in the US, 35 in Europe, and 26 in Japan, of which 19 are proton therapy centers and 6 are carbon ion therapy centers. I'd like you to stress, note this 35 in Europe, simply because they practice socialized medicine, and therefore the likelihood is that, what we think that medicine is commercial in the US, but these are, this is where socialized medicine is being practiced. So basically in Europe, we have 1 proton therapy center for every 21 million people. In China, it is for about 207 million people. In India, yet it is only 1 proton therapy center, which is the one in Chennai. And of course, I do believe that it is not only a privilege to work at the Proton Center, but also a responsibility, because it is an extremely exacting technology. It's not something that you can use casually. And it's also a responsibility because we have to see how or where it is applicable for Indian cancers. I do believe that it's only for some time that this is going to be the only proton therapy center in the country, because newer centers, newer technologies are available. There's recently, about 2 weeks ago, an announcement of a proton therapy program, which is going to be put in a usual LINAC bunker, using a chair for treatment, but not requiring a special bunker. So there are efforts on to make this treatment modality more, accessible. At present, what happens is there is a cyclotron, proton is created here, and then using a series of bending magnets, it comes into a usual looking treatment unit, but behind which there is a 3-storied structure to focus this 3 millimeter beam accurately at the tumor. So just very briefly, a cartoon. This is the tumor. This is how a normal photon behaves. The blue indicates how a normal photon behaves. It just attenuates as it goes along. It encounters the tumor, deposits some energy there, and then moves forward. In contrast, a proton will deposit all its energy at a pre-specified point, and nothing will go beyond, which now, because we haven't covered the entire tumor, we'll use another smaller energy, and then cover the whole tumor. And this allows us, because we are sparing the structures distal to the tumor, it allows us to increase the dose. For example, when we are treating chordomas, where there's brainstem close by, optic nerve close by, but we can still give the 70 gray that we need to give because the dose is not going distally. On the other hand, by allowing us to spare the normal structures, it allows us to reduce toxicity, which is the basis of its use in head and neck cancer. And it allows us to exploit radiobiology, because this sudden deposition of energy causes a lot of double-strand DNA breaks that cannot be repaired as easily as single-strand DNA breaks. The older machines, I'm not going to go into that except to say that they were older and poorer technologies. But the newer technology uses a 3 millimeter beam, which allows us to shape the radiation to match the shape of the tumor. And that allows us to give the proton therapy very conveniently and also very conformally. So who should get proton therapy? Various countries have evolved different methods of dealing with that. In the United States, they have identified something called group 1 cancers, where it is believed that the technology satisfies requirements, and therefore these patients can be offered proton therapy and covered under insurance. These are chordoma and chondrosarcomas, ocular tumors. But what I'd like you to note is it also is for advanced T4 and or unresectable head and neck cancers, cancers of the paranasal sinuses, and other accessory sinuses. So for this, insurance is considered, may be considered without any other evidence. For the others, it is evidence in evolution, and that includes non-T4 and resectable head and neck cancers. So currently, about 1% of all group 2 tumors and 2% of all group 1 tumors receive proton therapy in the United States. In Europe, they have taken a different route. They calculate the normal tissue complication probability using some formulae and previous research, and say that if there's a 10% reduced risk of having grade 2 radiation reactions, or 5% reduction in the risk of having grade 3 reactions, or 15% summed, then they will offer these patients proton therapy. For head and neck cancer, about 35% of patients qualify for proton therapy. This is the Dutch method of doing things. One of the known indications of proton therapy is skull-based cancers. And I would like you to discuss one patient who we had treated. 40-year-old lady had presented with blindness in the eye because she had this lesion which was infiltrating, adenoid cystic carcinoma, which was at the orbital apex from the ethmoid sinus. So as you can see, proton therapy allowed us to give radiation while sparing very critically the contralateral optic pathway. But what was most gratifying, and this patient remains well 2.5 years after treatment, is that she had lost her vision because of the encasement of the tumor, and later she recovered vision. So this is her VFA after treatment. We see a central scotoma because of the nerve fibers that were possibly damaged by the engulfment of the optic nerve. So yes, skull-based cancers are a standard indication of proton therapy. Another, and I'm not going to go into great detail, except that this was the chordoma patient who was re-irradiated, 36-year-old lady. You can see the chordoma, on the impinging on the optic nerve and on the tentorium. And then this is her post-treatment. The enhancement has disappeared. Another pre and post, the brainstem being pinched by the tumor, and the brainstem still being pinched by the tumor, which is no longer enhancing. This patient also remains well approximately 1 year after treatment. But we are interested in the routine head and neck cancers, the oral cancers. So we don't have information about oral cancers because this is an Indian disease. We do have information about oropharyngeal cancer. So this is from University of Pennsylvania. We know that oropharyngeal cancers, patients remain, even 1 year post-treatment, have better quality of life. So head and neck pain is less, xerostomia is less, and their ability to go back to a normal role is significantly better, which means compositely they are better. So 97% of patients in this study from UPenn went back to their normal role in life, vis-a-vis about 78% patients after head and neck, after IMRT. Similarly, another study, this is from Mayo Clinic. So a lot of work has been done at Mayo Clinic and MD Anderson Cancer Center. What happens here is that there's lower leg peg placement, less hospitalization, less end of treatment narcotic use, etc., in patients undergoing proton therapy because their side effects are less. So in this context, we are interested in oral cancer patients because that's our cancer. I'll start first with inoperable oral cancers. As I mentioned, that is an area that we are very interested in. Now, this is a 65-year-old man. He had an ICD in C2, ejection fraction of only 20%, very labile cardiac status, diabetic. He presented with loss of vision in the right eye. That is how his disease was discovered, that he had proptosis and he had lost vision in the right eye. And he had this massive tumor from the palate through the maxillary sinus into the temporalis muscle. We actually told him that it would be high palliation, but very daringly, we decided to go for 70 gray. And this is his proton therapy plan. This is his helical tomotherapy plan. As you can see, the helical tomotherapy plan is treating the buccal mucosa on the contralateral side, and the proton is actually sparing the buccal mucosa on the contralateral side. But what is most striking is when you see it in coronal. So this 65-year-old man, where we want to preserve cognition, his brain is being spared very beautifully. In contrast, the brain is being bathed in radiation when we are using helical tomotherapy. And this differential is the radiation dose that he did not receive because he received proton therapy. So this is how the structures were spared: contralateral parotid, constrictors, mucosa, larynx, supraglottic larynx, anywhere between 50% to 90% or more than that reduction in the dose being received by the normal structures. But it was absolutely a surprise for us to see that his tumor disappeared, his vision recovered, and he remains well 6 months after treatment. So this is what I was mentioning when we were discussing earlier, a very provocative sort of, thought. And we've done now a few patients, and I'm discussing another one. This is a 38-year-old man with a lesion involving the upper alveolus and the pterygoid muscles, severe submucous fibrosis, not able to even insert, a thick mouth bite. And we treated him radically. It was a difficult treatment for him, but we treated him with radical intent. And this is his scan 6 months after treatment. He too remains well, disease-free. And now it's about 9 months or so after treatment, he remains disease-free. Another lady, 72 years old, 2 synchronous primaries, multiple comorbidities. One, as you can see, in the tongue and one in the tonsil. The surgeons were not willing to operate on 1 out of 2. We treated her with proton therapy, and she remains well. An oral tongue treated with radiation along with the second primary in the tonsil, she remains well, and it's been more than 1 year after treatment. So definitely it is something that has energized us to think that this may be an option for inoperable patients. However, for the normal patient of head and neck cancer, there are many unmet needs that arise because of the treatment that they receive. For example, they may be fatigued. We have recently, this was published in Astro, that patients who receive radiation to the head neck region actually have problems in the brain. Please allow me another 5 minutes because I believe this will be interesting for you. So what we noted was, most striking was that the mucosa is being spared much better in patients receiving proton therapy. So this is a senior citizen, 69-year-old man in whom the mucosa has been spared. The mucosa, as we know, is responsible for many side effects: dysphagia, xerostomia, mucositis, oral pain. It has been found guilty for aspiration pneumonia, for something called toxicity syndrome, resulting in a higher risk of dying. For reasons of time, I will skip into all that. We do know that mucositis is a difficult thing for the patient, increases the risk of infection, aspiration, treatment interruption. And now this is a C8 tongue patient in whom proton therapy and photon therapy, and this is the extra radiation this patient has not received because of receiving proton therapy. So again, the buccal mucosa, as you can see, is being spared significantly better. This was a young doctor whom we treated with submucous fibrosis, and we were able to spare the buccal mucosa very well. As you can see, his inter-incisor distance is very low, and yet the tongue has mucositis because it has been treated, but the palate and the buccal mucosa have been spared very nicely. We have done an analysis. This has been submitted for publication and is currently under review. This tells us that the normal mucosa doses can be reduced as much as 50% in patients who have received proton therapy. This is valuable because so far we did not have any method of dealing with that. This also reduces the normal tissue complication probability in oral cavity cancers, whether it is unilateral or bilateral. So for even buccoalveolar cancer patients, there is a reduction in the risk of having oral mucositis. This is an 80-year-old lady, and as you can see, the mucosa is being spared very nicely. The mucosa is receiving only 10 gray vis-a-vis what it would have received in helical tomotherapy. That was 48 gray. So that is what we have been able to achieve with proton therapy for oral cancers. What is the outcome of that? The overall survival, about 87% at a median follow-up of 17 months for a mixed group, oral cavity as well as oropharyngeal. But what is most striking is that there have been very few patients who have had gaps. In fact, only 2 patients have had gaps out of 38 patients. Only 2 patients have had gaps of more than 2 days. Hardly anyone has required tube feeding. In spite of that, very few people have had loss of weight. So this actually is telling us that the treatment is much better tolerated. As you can see, even in the patients who were more than 70 years of age, only 50% of them required tube feeding. So there were some senior citizens, 70 years or more, who were able to complete their treatment without requiring tube feeding. And yet you see the weight loss more than 10% is happening in only 3 patients out of 38. This actually led us to believe that for geriatric patients, proton therapy is in head and neck cancer is going to offer. So these are 2 nonagenarians who we have treated, who have inaugurated this geriatric clinic. On the other hand, for young people, we wish to reduce the integral dose being received to reduce the risk of second cancer. In middle-aged people who have to get back to work, there is a randomized trial from the MD Anderson Hospital, which tells us that patients who receive intensity modulated proton therapy are much more likely to go back to work and have less absenteeism and composite work impairment as compared to patients who have IMRT. We've, of course, tried to find solutions for Indian problems. So there is this titanium plate. We have simulated this. Our physics team has created, did the sort of groundwork before we started treating patients. We have devised these various mouth bites this is for a tongue patient, a buccal mucosa patient. We use this mouth bite to push the tongue away. This is to take away the palate when we are treating the tongue. This is a patient who had very poor mouth opening, so we put a Riles tube inside so that he could breathe through that. And I'm very happy to report that our data on how these patients should be prepared for treatment has recently been published in the European journal called TIPSARO, which looks at this particular aspect of radiotherapy. This is my last slide, and I thank you for giving me the extra time. We recently started looking at our cohort of proton therapy patients versus helical tomotherapy patients, exclusively of post-op oral cavity. So what you see here again is that in spite of the fact that we have a higher proportion of patients who have stage 4 disease in helical tomotherapy in proton therapy arm, we also have a higher proportion of patients who are elderly, more than 70 years, in the proton therapy arm. We find that the weight loss is less in the proton therapy arm, whether it's more than 5% or more than 10%. And we also found that the tube feeding requirement is less in these patients, overall indicating that for oral cancer patients, proton therapy is a less toxic treatment. Of course, we need to add numbers before we have, a statistical significance. We have also been able to accelerate treatment. So you know that in head and neck cancers, increasing the dose is not of value, but shortening the treatment time is of value. And that has been possible for us using proton therapy across board in head and neck sites. So to conclude, what is it that we want for our patients? We want longer lives free of cancer. And for that, we can do dose escalation and exploit radiobiology of proton therapy. We also want their quality of life intact. And therefore, with proton therapy, by allowing us to reduce the dose to the normal structures, reducing the risk of second cancers, and reducing the risk of cognitive impairment in various ages and stages of life, that is where the role of proton therapy comes in oral cancer. I'd like to acknowledge the big team that has made it possible. This is Dr. Jalali, Dr. Srinivas, my colleagues who look after different sites, some of the residents. Dr. Nofel is our physicist who's done some seminal work by which we have been able to reduce skin reactions, which had earlier been a concern in proton therapy patients. Dr. Daya, our physicist, and most of all, our patients for having trusted us in what was a new technology for India. Thank you very much for your attention.
Thank you, ma'am, for this excellent talk and insight into the much talked about proton therapy, proton-based radiation therapy. So is there any time for questions, or so we can take one or two questions if someone wants?
Yes, sir.
I just wanted to know that if we are giving proton therapy, what do you do with the chemotherapy then? Like if
It doesn't change.
it stays.
It doesn't change. So no treatment protocols change, except that we are able to shorten the treatment by giving 6 fractions a week in the latter part of the treatment. So some acceleration in spite of using chemotherapy.
Okay.
But otherwise, nothing else
Nothing
changes. Our target delineation doesn't change. But in spite of all that, the toxicity becomes much less.
Thank you.
Back on the slide. Last slide. The conclusion slide.
Sorry,
Conclusion slide.
this?
How do you reduce the risk of second cancer that you have written here?
So basically, the integral dose that is received, sorry, so this slide. So this, the 6 gray isodose volume correlates with the possibility of having second cancers. So this is a proton therapy plan, and this is a photon plan, a helical tomotherapy plan. So what you're seeing here is that the integral dose received by the body, this entire section has not received any radiation. So there are many population-based studies which now tell us that the hazard ratio for developing second cancers after proton therapy is only about 0.3.
It's because of radiation therapy.
Yes, yes.
Thank you.
So, ma'am, I have one quick question for you, that in your experience with treating the patient with photon and now with proton, what is the in-field recurrence rate difference between these two kind of beams? Do you feel that in proton therapy, the patient primarily treated with proton has less in-field recurrence when you compare with the patient treated with photons?
So as yet, I don't think we have that kind of information for head and neck cancers in general. We have that information for paranasal sinus tumors. For paranasal sinus tumors, there are multiple studies. There is a meta-analysis that tells us that locoregional control, disease-free survival, and in certain situations, even overall survival is more for patients who have been treated with proton therapy. For the other cancers, at present, the indication remains reduction of toxicity, but we are waiting for the randomized trial that has completed recruitment, multi-institutional randomized trial, which has been spearheaded by MD Anderson. We are waiting for those results.
And the other thing, ma'am, that when we read about the radiobiology difference between these two kind of modalities, do you feel that proton is clinically also more effective into resistant kind of tumors when we compare with photon?
So that is very clear when we look at, entities like, for example, the gentleman I showed you, that I think the odds of curing a patient who has palatal lesion extending into the orbit, I believe that we seem to be getting this sort of sense. On the other hand, if you look at something like chordomas, those are considered radio-resistant tumors, and the treatment of choice in chordomas is proton therapy, and possibly their radiobiology plays a role. And that is chordomas across sites, such as sacral chordomas, such as paraspinal, dorsal spine, cervical spine, as well as skull base.
Any other questions? So I thank you, ma'am, for this excellent deliberation on proton therapy.
Thank you very much for the opportunity.
So thank you so much, Dr. Sapna ji, for enlightening us about the proton therapy.